Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to Health Matters, a comprehensive chat, your Tuesday slot by the Islamic Medical Association, a health program from health professionals trying to empower you and empower you through this forum. Today we're discussing asthma as our topic, and we welcome our honored guest, Professor Akhter Goolam Mohammed, from the medical Medunsa campus of the University of Limpopo, and also doing some limited private practice in Pretoria. Assalamu alaikum, Professor Goolam.
Wa alaikum salam wa rahmatullahi wa barakatuh, Yakub.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين والعاقبة للمتقين والصلاة والسلام على أشرف المرسلين سيدنا محمد وآله وأصحابه أجمعين. I just thought today's tarbiyah will touch on a little bit about the love of Allah and how do you attain that and what's the reward for that. And I've taken the article from Professor Fazlur Rahman Ansari's book, and he quotes the Quran, قُلْ إِن كُنْتُمْ تُحِبُّونَ اللَّهَ فَاتَّبِعُونِي يُحْبِبْكُمُ اللَّهُ. If you love Allah, imitate me, follow me, and Allah will make you His beloved. All these categories are categories of the beloved, which is the shuhada, the siddiqeen, and the salihin. But what changes come into the human being when he or she becomes the beloved of Allah? In a hadith al-Qudsi, which is a direct quotation from Allah, when my servant loves me and proceeds towards me with the intensity of love, leading by righteousness, godly and pious life, and beyond what I have described as obligatory, then he arrives at that stage where I come to love him. When I make him my beloved, I become his ears with which he hears, his eyes with which he sees, his hands with which he grabs. I become his feet with which he walks, and a tongue in which he speaks. And what greater reward can you have to have all your faculties being governed directly by Allah and a representation of Allah? Allah is unique and indivisible. He does not incarnate into any being. But we know if Allah becomes anybody's eyes, we can understand that from which sight nothing would remain hidden. And as for Allah becoming the ears, no sound will remain hidden from such a person. And when Allah becomes your feet, there would be no place in the universe whose feet cannot go. What a reward. And what a goal for us to try and achieve, is to follow the rightly guided teachings of the beloved Nabi Sallallahu Alaihi Wasallam and the Quran, and to come to that point where Allah would love us as we love Him, and we then the representation of Allah on this earth. We go on to today's topic of asthma, Akhtar. And obviously it's a very common condition. But from the past, and I think it still exists today, that when we make the diagnosis of asthma to the patient, it still has that bit of a stigma, probably not as much as it used to in the old days, but people get this kind of an emotional response at why do I have asthma, especially when it comes to parents when the diagnosis is made in their children. Do you still experience that? And can you please tell us exactly what is asthma?
We still experience it a little bit, especially in children, where the parents don't want to accept the diagnosis sometimes of asthma. But I think people are now beginning to understand the disease a bit more. Basically, asthma is an inflammation of the airways. We didn't realize that before. Before, people only talked about the narrowing of the airways. But we realized that the narrowing occurs secondary to inflammation. So the first thing that occurs is that there's inflammation in the lining of the lungs, called the bronchi. And then subsequently, with that inflammation, we then get spasm of the airways, and then we get narrowing of the airways. And the inflammation persists, but the narrowing can go up and down. Okay, so and that's what causes the symptoms usually, is when you start getting narrowing of the airways. And the narrowing is intermittent, so that's why we call asthma as an intermittent disease. And most asthmatics will tell you that sometimes I'm feeling well and sometimes I'm not feeling well. And it's mainly because of that narrowing that occurs at certain times.
You have a slide of the definition. Perhaps we can get slide number 1 coming up and to kind of explain the definition. But that is a comprehensive, in a nutshell, explanation of what asthma is. And when you're referring to inflammation, exactly what is inflammation? Because many times patients come to us and they say, the doctor said, I have inflammation, and some of them confuse that with infection. And it's not necessarily always an infection that causes the inflammation. Is that true?
That's true. Yeah. Particularly in asthma, the inflammation, in fact, is not related to infection. Although infection can precipitate the inflammation is mainly caused by a white blood cell called the eosinophil, whereas most infections, the inflammation is related to another type of white blood cell called the neutrophil. So mainly we have neutrophilic inflammation when we've got infective causes, particularly bacterial causes. And when we've got asthma, it's mainly caused by eosinophilic inflammation. And as we saw in that slide, there's different definitions of asthma, and the one that we've seen, this one is by the Global Initiative for Asthma, also known as GINA. And as they've said, it's mainly the chronic inflammatory disorder, and there's many cells that may cause this inflammation, but there's also an increase in the airway hyperresponsiveness, which is the narrowing of the airways. And then that leads to symptoms, and the symptoms which we often get are the symptoms of wheezing, breathlessness, shortness of breath. As we've said, coughing is a common symptom as well of asthma.
So we'll come back to the symptoms again. How common is this condition?
The condition is nowadays very common, and it seems to be related mainly to urbanization. Okay, that seems to be the predominant pattern that we're seeing. So in rural patients, for example, the incidence of asthma is much lower. In urban areas, the incidence is much higher. And there may be a number of factors that are responsible for this change in prevalence. One would obviously be the allergens in the environment, and particularly we're thinking of pollutants in the environment. And so, pollution is much more in urban areas than it is in rural areas. There's also a close proximity of people to each other, so viral infections can occur more commonly. And so you may pick up viral infections. And then modern lifestyle, particularly in terms of diets, etc., that may also predispose to differences in development of asthma. One of the other theories is what's known as the hygiene hypothesis. That means as we become more urbanized, we tend to become more conscious of hygiene. We clean our environments excessively, and the incidence of bacterial infections, particularly in children, is diminished, and that may then result in a different type of cascade of your immune system, which then goes onto a different type of inflammation. Whereas if you were exposed to bacteria early on in your life, your inflammatory system behaves in a different way. So this is known as the hygiene hypothesis. And they've also done studies where they've looked at, for example, exposure to pets. Children that have exposure to pets in childhood, particularly farm animals, they get much less incidence of asthma than do urbanized children.
So a bit of a contradiction, right?
Yeah.
Because a hygiene hypothesis is referring to this drive towards more cleanliness, but at the same time, with urbanization, you've got pollution.
Yeah.
So you've got two contradictory theories, both trying to explain the trigger factor that causes the inflammation.
Yeah.
But obviously, it's not a definitive thing. I'm sure as time goes on, more research will show which theory is more prevalent.
Well, I think it's both theories.
It works in both. Okay.
Yeah, so because the hygiene hypothesis is what modulates your immune system to go a certain way. And then once that system or that inflammation is developed within your body and your immune system gets a certain degree of tolerance to some things, it also has intolerance to other things like smoke and viruses, etc. Okay. So it's not so much that the immune system is abnormal in a sense that it is driven towards one pathway rather than another pathway. So the balance within the immune system is lost more than actually a particular type of immune loss.
Okay, good. We've got some slides on the prevalence, and perhaps those can come up, slides number 4, 5, and 6, and that will kind of show the prevalence. Anything more you want to say on the prevalence? Is there like a difference between the different hemispheres internationally, different countries, any particular geographical differences?
Yeah. I mean, this article you can see is from Time magazine, and it's showing that there's about now 300 million people worldwide that suffer from asthma. Sure. And there's about quarter million annual deaths still attributed to the disease, even up to this day and age. Sure. So it's quite common.
But does the death occur directly from asthma or the complications of asthma?
No, usually that 250,000 we're talking about is directly from asthma itself.
Okay. And this is obviously undiagnosed and not managed well?
Mainly undiagnosed and not managed well.
Okay.
But we do also get a small category of patients that get what we call critical asthma, or asthma that's precipitated by something, and suddenly they get an episode of bronchospasm which is uncontrollable. That's a very small and minor group, but the majority, as you've pointed out, is due to poorly controlled asthma.
Okay. And I mean, it's growing at such a rapid rate as its site shows. So are we diagnosing more and more because of better technique or better awareness, or is it a combination of both?
I think it's a combination of both. Okay, so the prevalence itself is increasing, and we are diagnosing it better. Okay. We can diagnose it much better today.
Okay. So obviously, when the diagnosis is made, but before you can actually make the diagnosis, patients present with a set of symptoms, and then the signs that the doctor picked up. You mentioned some of those in the definition, but perhaps maybe you can just give us a little bit more detail as to what kind of presenting symptoms would give a cue and a clue towards asthma, and then again, what further diagnostic methodologies you'd use to make the final diagnosis.
Yeah, the most common symptom that asthmatics present with is tightness of the chest, and so they will feel that the chest is getting closed, and they will get short of breath. Okay, subsequent to that, they also may present with coughing, which is because of irritation and inflammation in the airways. And those are the three major symptoms that they would get. And then if you examine them, you can often hear wheezing or whistling in the chest. And sometimes people that are close to the person can often hear their chest wheezing or whistling, and they will report that. The symptoms are also vary according to the time of the day, and most asthmatics' symptoms are worse in the early hours of the morning. So around about 4 or 5 o'clock in the morning, that's the time when they get their chest being the most tight usually, and the symptoms are the worst. Other things that precipitate the symptoms would be exercise. So we get, for example, patients that present with asthma that's mainly exercise induced.
Okay, I think we'll continue with that discussion, and then the lines will be open for your calls. The number will appear at the bottom of your screen shortly. We're going to take an ad break, and then we'll continue, and please bring in your calls. Professor Akhter Goolam Mohammed will attempt to answer your questions. Assalamu alaikum. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters, a comprehensive chat by the Islamic Medical Association. Tonight's topic is asthma. Our guest tonight is Professor Akhter Goolam Mohammed. We went through the definition, the prevalence of the condition, a fairly common condition. We're discussing predominantly adult asthma. The lines are open for you to call in 011 086 7700 or 1 or 2 or 3. The number appears at the bottom of your screen. And we had reached a point now we were discussing signs and symptoms, Akhter. What are the symptoms or signs that you may not have mentioned?
Yeah. The other thing
maybe
is...
Maybe a recap. Yeah.
Basically, the other symptoms that are often associated with asthma are symptoms of allergic rhinitis. So because asthmatics are what we call atopic, or they have inflammation, they don't only get inflammation in the airways or the lining of the lungs, they get they get inflammation elsewhere as well, including the nose, and so they present with what we call allergic rhinitis. They also get skin allergies, particularly eczema. So those two conditions are very commonly associated with asthma, and it's part of what we call atopy. And allergic rhinitis then obviously would present with seasonal changes, particularly during spring and autumn time of a runny nose, and that condition is often associated with asthma. Other conditions that may often be associated with asthma are also gastric acid reflux, and we've increasingly recognized that gastric acid reflux plays an important part in terms of both the development of asthma and also precipitating asthma attacks as well, and leading to poor control of asthma as well. So gastric acid reflux is another condition. We also now, with the other thing that's been important is the obesity epidemic throughout the world. And the obesity epidemic is another factor that is contributing towards the higher prevalence of asthma as well.
How do you explain that?
So we're not sure what causes this, but certainly obesity itself seems to be more commonly associated with asthma. There are a number of possibilities that may result in asthma with obesity. One is the gastric acid reflux, which we've mentioned earlier on. But another one is also a restriction of breathing as well.
Okay.
Because of obesity, the airways are not as compliant as they should be.
So that's a mechanical thing.
So it's a mechanical thing where we actually get the collapse of the airways, and that contributes towards the asthma as well.
So obviously it's quite multifactorial, and so you won't just get one particular scenario that will fit into the picture, and patients will present with different things, like most things in medicine. You mentioned 3 conditions in terms of allergies. Was obviously the rhinitis, sinusitis, the symptoms of the chest, and the skin conditions. But we also sometimes nowadays in spring that we're seeing quite a bit of this allergic conjunctivitis. And do you sometimes see patients coming with a red eye and then sometimes mistaken as an infection, pink eye, but meanwhile is an allergy, and then also an associated cough, which may be asthma, and sometimes a misdiagnosis is then made that this is like a viral illness, but the bottom line cause may be the allergy itself?
Yeah, certainly. Allergic conjunctivitis is also associated with allergic rhinitis and asthma as well. And often the diagnosis, as you point out, is made, particularly during springtime and autumn time, diagnosis is often made of an infection, either due to a virus or bacteria, but most commonly it's more likely to be an allergic conjunctivitis.
So obviously the diagnosis can be missed, and that is why sometimes we find that patients are not managed well enough, and then they have the recurrence of symptoms coming through because they've been inadequately or inappropriately treated.
Yeah, that's true. So what we need to do in order to make a diagnosis, obviously the symptoms are very important. So the symptoms, as we've discussed, that you present with the cough and the wheezing. But sometimes you may not present with all 3 of the symptoms.
Yeah.
Okay, so you may only present with a cough, you may only present with wheezing, you may only present with shortness of breath. And so if you present with only one of those symptoms, sometimes it's difficult. So if it's a cough, people may think that that's just a viral infection, or they may think it's a bacterial infection. If it's wheezing, then then it's much less likely to be something else. Okay, and if you get shortness of breath, obviously there's a number of causes of shortness of breath, including cardiac causes. So any of those things then might be mistaken for asthma, and particularly in older patients. So if you get asthma as a child, it's often easier to diagnose. But if you get asthma developing late on in life, particularly middle age or even elderly patients, and then we have to look at other causes that it might not be asthma. So cardiac failure is particularly one of the things that we look at to make sure that that's not the cause of your symptoms.
But sometimes when they present in adulthood, maybe in the age of 35, 40, and they got the classic symptoms of asthma, do you think it's perhaps a misdiagnosed asthma as a childhood that went into remission and then resurfacing due to some trigger factors in adulthood?
Yeah, it could be either childhood asthma that went into remission and then is exacerbated again, or sometimes it's de novo new asthma. Okay, so it can be both categories. And that's where the other diagnostic tools are helpful for us. So obviously on clinical examination, when the doctor examines your chest, he will look for features of what we call hyperinflation, where your chest wall actually enlarges. They'll listen to your chest and they will hear wheezing, which is, as I've pointed out, is most commonly associated with asthma. In very older patients, the other possibility will be emphysema, which is mainly due to smoking. So that condition tends to occur much more commonly in smokers, but not to say that smokers can't develop asthma either.
Yeah, of course.
So both of them, can cause wheezing, and those are the most common causes. And then sometimes even with cardiac failure, we can get wheezing in the chest, because there's water that builds up in the lungs and that narrows the airways, and then we get wheezing. So the next step would be obviously examination, and then the best test subsequently will be what we call lung function testing. So we can do a simple lung function test, and that's called the peak flow, but that's not very reliable.
Can we come to that after we take the next caller?
Sure.
Assalamu alaikum.
Walaikum salam.
How are you, sister?
I'd like to find about the diet for an asthmatic patient, especially with regards to children and also Indian food. Jazakallah.
Okay, so basically the relationship between diet and food and asthma.
Diet and food,
especially in children.
Yeah. Children especially may have allergies, and one of the commonest ones that's associated with in the food industry is peanuts. Peanut allergy is very common in children, and that may precipitate acute attacks of asthma. And other dietary things as well, including preservatives in particularly in drinks like orange juice, etc. Often with the sweets and chocolates, which might also have colorants, etc. in them. So dietary things may precipitate it. There's often also, cow milk allergy, for example, as well. Wheat allergy, which may also precipitate asthma. So a number of these things may precipitate it. But the thing to be careful about is not to eliminate everything in the diet. And I think that is the problem that sometimes we face, many patients would come to me and said, no, they told my child that they're allergic to cow's milk, so they don't have any dairy products whatsoever. But they're not necessarily, if you do blood tests on them, they don't necessarily have these allergies. So one mustn't avoid all the foodstuffs, but avoid specific ones. And the important thing there, we advise the parents often, is to watch their children and see what specific things in the diet might precipitate the acute attacks, and then to avoid those specific triggers.
But are there any specific, more common allergens or triggering factors in the preservatives like tartrazine, and that has that been proven? Because that was in vogue at some stage.
Yeah, they still are. I mean, tartrazine is one of the sulfurs, acetyl salicylic acid, which is present in a number of products, can also precipitate it as well. So there's a number of triggers, and the list of triggers runs into a list of about 1,000 items. Okay. So it's difficult to differentiate particularly. So the history in any particular person is very important.
But then what's the value of the allergy testing that is being done? Because obviously those are testing the more common allergens, right?
Those test the most common allergens. So the main thing that we would test there is just to make sure that the patient has got atopy. So that's to define the type of asthma they got. So we measure what's known as the IgE, or the immunoglobulin E. That's a molecule that actually is involved in inflammation in asthma. And if you've got that, if that's elevated, then that suggests to us that your asthma is due to an allergen, and it's caused by an allergen. If that's not elevated, then it's less likely that you got what we call atopic asthma, and you may be having more likely what we would call intrinsic type of asthma, rather than an extrinsic type of asthma, which is mainly caused by allergens.
And does the management in the two differ?
Not much these days. Okay. You can then subsequently do tests for specific allergens. Okay, so we may do for the common allergens, as you pointed out, is all that we can really do. So it would be things in the environment. House dust is the most common that we would do, and it's when we say house dust, we don't mean the dust itself, but the content in the house dust, which is the mite. So it's the mite that we're really testing for. And some common food allergens, dairy products included, eggs, peanuts, those sort of things. Those are the common ones that we can test for. Common animals that you might be exposed to, particularly things like cats and birds, they might precipitate asthma. So those allergens we test for. But the first test that we would do is a total IgE. So if your total IgE is normal, it's not necessary to then go on to do all the specific type of allergens. And if it's normal, then we don't have to worry about allergy. But you've discussed the question of whether we should actually be doing, whether the management is different. Generally speaking, no. But to some extent, yes as well. Okay. Because if they've got associated allergic rhinitis and atopy, then we want to control those things as well. So they are more likely then to get antihistamines to control those symptoms. Okay. Whereas a patient who's got mainly intrinsic asthma is not going to mainly benefit from antihistamines. And also recently there's been a drug that's been introduced that that targets IgE itself. So if your IgE levels are very high, then we can use a drug that targets that particular molecule.
We'll discuss the benefit of that when we come back from the next ad break. But of course, we'd still like to hear from you with your calls. The number is at the bottom of your screen. Please do call in. Professor Goolam Mohammed is here to answer your questions. Today's topic is adult asthma, and we'll see you shortly after the ad break. Assalamu alaikum. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters, a comprehensive chat by the Islamic Medical Association. Our topic tonight is adult asthma predominantly, but Professor Akhter can answer questions on other age groups too. And the lines are still open. You can call in. The numbers at the bottom of your screen. Before we left, we were discussing some kind of avoidance and preventative measures. We're talking about diet, but Akhter, also you mentioned the house dust mite as a big culprit in the trigger factor for asthma. We find a lot of people then tend to say, look, should they remove all the carpets from the house and go onto parquet or something else, purely because of the fact that that particular flooring may harbor the house dust mite? What's your view on that?
It does certainly help because carpets do tend to accumulate more dust, and the house dust mite tends to grow in carpets. So it is much better for atopic individuals to remove carpet type of material and go on to other flooring like tiles or wooden flooring. So certainly it does help. Okay. In terms of the bedding as well, regular cleaning of the bedding does help. But there's been a number of studies done with mattress protectors, which actually then coat, and so you don't get the mites growing on that. But those studies, unfortunately, have been disappointing. So we don't then recommend that aggressive avoidance in terms of the home. So, but avoiding the carpet certainly does help. And most patients who've got atopic asthma or allergic rhinitis do benefit from removing carpets in the home.
Okay, and then we're talking about diagnostic cues, and then obviously after the doctor examines the patient, then there's certain investigations you can do, but there's some simple ones like the peak flow meter, which you kind of just touched on before the caller came on. So the lines are still open. Please do call in, but while we're waiting for your calls, perhaps we can discuss peak flow meter and diagnostic techniques. Yeah.
Okay, so Yakub, we have it's a very simple device, okay? This is what we call the mini Wright's peak flow meter. So it's a small one, so it can be handheld, and it's got markings on it, okay, which start from 0 to 500, and depending on your height and your age, you should be able to produce a certain amount of peak flow.
Which is what?
Which would, well, it would vary depending on your height or weight. So for a child, it will be 250 to 300 sort of thing. For an adult female, it will be 400 to 450. For an adult male, it will probably be between 500 and 600.
So that's like a normal range.
So that's the normal range that we would expect you to blow. And if you blow below that, then obviously your asthma is not well controlled, or you do have asthma. We can use that to make a diagnosis. And we can also then see how well you respond to treatment as well. So it will be a monitoring tool as well. And when your peak flow goes down, then it will suggest to you that your asthma is now triggering and you might need to step up your treatment. So home peak flow monitoring is often done. So like I've showed you, this one particularly has just got values, and your doctor can advise you on what particular values are applicable to you. And sometimes you can get one that can actually, you can actually monitor that. And so we can put in on the side, we put in markings. So this is what your normal value should be. This is where your asthma is getting worse. And if it goes below a certain level there, then you need urgent medical attention. Okay, so we can actually do a peak flow meter that actually can set in the values that you have.
How important is the technique of blowing into the peak flow meter?
It's not that important, okay? Usually it's a very easy technique, but you do need somebody to show you initially what to do. So you would place it on your mouth, and then you would take a deep breath in, and then blow as fast as you can, okay? Very rapidly. So it would be in, and then blow out very rapidly, and then we can then measure what exactly your peak flow is.
So this is a good tool to use at home. It's self-monitoring, similar to what diabetics would use for their little glucometers.
That's right. And in fact, these days you even get, like the diabetics, you can get an electronic one.
Okay.
Right. So it can read that out. And some places in the world, that these electronic monitors are connected to the doctor as well. So they can transmit your data to the doctor, and the doctor can monitor you. And if they pick up an alert, they can inform you that you've got a problem with your asthma. So it's a good monitoring tool, and it's also a good diagnostic tool as well.
The lines are open. Please do call in 011 086 7700 or 1 or 2 or 3. The number is at the bottom of your screen. So moving on, that's a very simple diagnostic tool, but sometimes the diagnosis does become a little bit more complex. So what do you do then?
The next step is, and this is the most important diagnostic tool in diagnosing asthma, is what's known as a spirometer. Okay. Now you can get different types of spirometers. You get what's known as an office-based spirometer, and you get bigger spirometers, which are lab-based. So most of your general practitioners would be able to, and your general physicians would be able to have this office-based spirometer. But not many general practitioners have it, but certainly physicians do have office-based spirometer. And it's similar to the peak flow meter, but it's able to measure much more data. And we can measure that at baseline, and then we give you a bronchodilator, and we measure it subsequently again, and we see if there's a difference. And if there's an improvement with the bronchodilator of more than 12% in a parameter called the FEV1, then we know that that's diagnostic of asthma. So that's how we would make the diagnosis. So that's the most important diagnostic tool that's available to us. If you go to a pulmonologist, then there are even more sophisticated tests that they can do. So they can put you into an instrument called a body box. And in the body box, they can actually measure your airway resistance as well. They can actually also measure the amount of air that's left behind in your lungs. And that goes up if you've got asthma and if you've got COPD, as we talked about earlier on. Those two conditions will increase what's known as the residual volume. So that would be another diagnostic tool. But that most commonly would only be in the laboratory setting with a pulmonologist.
Okay, so that's a bit more sophisticated and required in certain conditions. We have another caller. Assalamu alaikum.
Wa alaikum salam. I'm speaking from Pietermaritzburg. And my son Muhammad Aslam is after 24 years suffered with asthma attack, very severe attack. And we had to admit him to hospital, and he was treated there. And I think this gadget, what you showed me on the TV, is very essential for him. May I know where I can purchase it?
Sorry, repeat that, please.
Assalamu alaikum.
Hello?
Yes.
What is your question?
The question is that the stuff what doctor has shown now,
Then
where do you purchase it?
You could purchase it at any pharmacy. You can inquire from your pharmacy. You could also ask your general practitioner. He might be able to get some for you. So it's readily available. And it would be quite an easy tool to use. If he was admitted to hospital, his physician could then also tell him what sort of normal levels he should have on that peak flow meter.
Jazakallah. Assalamu alaikum.
Jazakallah for your call, sister. So basically, it's a question of where do you obtain these devices.
Yeah.
So are they available at the major pharmacies?
Most major pharmacies should have them available.
Okay. All right. You were talking about diagnostic tools. So the lung function, the spirometry, it gets a bit more sophisticated. You end up with a pulmonologist. So at what point would you then get referred a patient from a general practitioner to the pulmonologist like yourself? Is it when it's not controlled, or is inaccurate diagnosis made? What do you find usually?
Yeah, I think both those reasons are reasons for referral. So if the general practitioner is not sure of the diagnosis or has not made a diagnosis, then they will refer the patient to us to confirm the diagnosis or to rule out other lung conditions that might be relevant to that particular patient. Or otherwise, they might have an asthmatic patient who is not being well controlled or getting recurrent episodes of asthma again, might needing recurrent episodes of hospitalization as well. And the control is poor, and then they would then refer the patient to us for management mainly. So it would be either for diagnosis or for management.
Okay, so that brings us obviously to the most important part. The diagnosis is made, inshallah, like a proper, accurate diagnosis of asthma. We're now looking at that alone without its other things that might be triggering it. Where to from there? Because patients tend to say, if I'm on pumps, my asthma is worse or it's more severe. Obviously, that's not true, but obviously that's what they feel.
Yeah. Well, then the management, as I've pointed out to you, there's two components that we know about the asthma. One is the inflammation. The other one is the narrowing of the airways. So both need to be treated, okay? And the most important one that needs to be treated is the inflammation.
Okay.
If we control the inflammation, we decrease the incidence of narrowing, and we decrease the time to before you get any spasm, okay?
Right.
So this is what a slide of airway inflammation looks like. So in a normal patient, we can see on the left-hand side, that's the lining of your bronchi. It's smooth with little hairy cells. And in an asthmatic, it gets quite deranged, okay? And we get inflammation. So that inflammation is what needs to be treated. Now, inflammation, the other picture that's coming up is just showing you the narrowing of the airways with the associated inflammation. So on the left-hand side, you've got a normal airway. In the middle, you've got an airway in people with asthma, with inflammation. And when you get more severe asthma, then you get mucus plugging and the airway becomes very narrow. So we don't get passage of air going through that.
And that obviously results in the different severities of symptoms.
That results in a different severity of symptoms. That's right.
So then the management, I mean, the pumps, some patients are on one inhaler, others are on a different. And then there's obviously different types of inhalers, which we can discuss shortly. But what is the first step? They treat the inflammation and then the narrowing together.
That's right. If you've got only mild intermittent asthma, that means only now and then you get asthma, particularly the exercise precipitated type of asthma. And then we would use only what's known as a bronchodilator or a beta-2 agonist, okay? So that would be a pump like Astavent or Ventolin that you would only take before you do exercise or at times when you might get your airways getting a bit narrow with exercise. So that you would use on as necessary basis. That's a very small percentage of our asthmatics, okay? More commonly, you've got underlying inflammation, and because you've got underlying inflammation, we need to treat the inflammation. And what we treat the inflammation with is cortisones, basically. Although people have in their minds always a worry about cortisones, and they feel that cortisones are going to have a number of side effects. But the dose that we use is in inhalers is minuscule.
And it's going to the airway, not into the blood.
And majority of it goes into the airway. Very little gets absorbed into the bloodstream. So there's different types of cortisones or different types of steroids that we would use. Beclomethasone was the original steroid that was used, but we've got now newer ones like budesonide and fluticasone, which are more longer-lasting type of inhaled steroids. But all of them work reasonably well.
You guys work on a stepwise categorization of the severity of asthma, right?
Yeah.
Slide 9 would probably show us that stepwise, and then you base your treatment on that.
That's right.
Okay. Discuss that a bit.
So this is, as I've showed you, we see step 1 is what we call a short-acting beta agonist is needed. So that's only for mild intermittent asthma. Then we start using low-dose inhaled corticosteroids. So that will be lower doses. We would classify that as between 250 to 500 micrograms per day of budesonide. And then if that's not being controlling your asthma, then we step your treatment up. So we will use the low-dose inhaled corticosteroid with what we call a long-acting beta agonist. So that will be something called salmeterol or formoterol, which are long-acting. And if we use both, we can use them in 2 separate pumps,
or we
can use them in a combination pump. Okay. Most commonly these days, we use them in a combination pump. The combination pump has certainly been shown to be much more useful than the pumps on their own. If that is not being controlled, then we can add in, on step 4, we add in other things like a leukotriene antagonists, or we use an old drug called theophylline, which still works very well. And And then if that's not being adequate, then we go on to higher doses of your inhaled corticosteroids. And finally, if we're still not being controlled, then we may consider using oral cortisones. Okay, but it's these days with modern techniques and modern inhalers, it's very rare that we need to use oral cortisones. We only usually need to use oral cortisones at times of acute precipitation of an attack. Otherwise, very rarely in between do we need to use oral cortisone.
So your general message for patients that got the categories from the mild, moderate to severe, they'll always be on an anti-inflammatory pump, which got its inhaled corticosteroid in it.
Yes.
And then they would be taking the reliever pump as and when they need it. Yeah. And then, obviously, if they go into the more severe categories, they may be taking a tablet like the Singulair or the Montelukast.
That's right. So that would be the stepwise approach that we would use.
Sometimes we find that the patients are on inhalers. They don't really have a severe form of asthma, but the technique in taking the inhaler is not been refined. Yeah. And that's the problem, and the drug really doesn't get to the airways the way it should.
Yeah.
You still finding that a problem?
It's one of the major reasons for referral, and sometimes we pick that up very easily when we ask the patients to show us how they use the inhaler. And if they're not using the inhaler adequately, then that often leads to poor control of asthma. And in fact, it's one of the major risk factors of poor control of asthma. That's why I said these days we very rarely need to use oral corticosteroids, because if we teach our patients how to use the inhalers properly, then we don't usually need to use oral cortisones.
The lines are open. The number is 011 086 7700 or 1 or 2 or 3. Number is at the bottom of your screen. Please do call in with any questions you may have on asthma. We have Professor Goolam Mohammed here, and we've been discussing a comprehensive discussion actually on asthma. We started off with the definition and moved through the signs, symptoms, and we're now at the treatment level. Are there any other comorbid or coexisting conditions which kind of complicate the management of the asthma?
There may be other conditions, sure. Patients, for example, that might have associated depression, for example. Okay, so they don't then are not motivated enough to take their medication, for example. Okay, teenagers, for example, because of peer pressure, also would often not want to take their medication regularly. So those conditions would then, affect this thing. Smoking, as we mentioned, is one of the worst problems that we face. And in fact, recent studies have shown that asthmatics that smoke do worse than anybody else. So if you've got an asthmatic who doesn't smoke, and on the other hand, you've got a smoker who develops chronic obstructive airways disease, and in between, you've got an asthmatic who smokes, they get the worst of both worlds. So they get the COPD type of illness, and they get asthma. And in fact, their outcomes are much worse. And it becomes very difficult to control the asthma. And I know certain pulmonologists, in fact, that would refuse to treat an asthmatic that has been smoking.
Okay. All right.
So they would say
punitive.
They're being punitive and say, I would not see you in my practice till you give up smoking. Okay. Because of that, but it certainly is one of the problems that we see.
You mentioned GINA as your global body, and you guys have come up with certain goals of management. Slide 8 will show us those goals of management. What do you think? How far are you guys in achieving those goals?
Well, most studies show that we don't do too well, unfortunately. Okay. But I think that on the first level we do well, which is to achieve and maintain control of symptoms, and also normal activity, the problem is to maintain pulmonary function, and that sometimes is difficult. That's where you need close monitoring, and that's why it's useful to be followed out regularly by your general practitioner or by your pulmonologist, depending on your degree of severity of asthma, so that you actually do get regular lung function testing done, We also we're doing reasonably well in terms of preventing exacerbations as well. A recent study done in South Africa actually shows that of all the groups that are treated, if you're in the hands of a pulmonologist, you do the best actually. All right, not unsurprisingly. Okay.
Okay, we got another caller. We'll talk about your business just now. Assalamu alaikum.
Alaikum salam. I'd just like to find out from the doctor if you have a blood count that is very low. I don't know whether it's now low blood or whether it's now your anemia in it. But could that have any bearing on one who's having a wheezing chest? And because like if you have never had asthma in your entire life, and all of a sudden late in your years you start developing that, could that be a reason why?
No, it's unlikely that it's related to anemia or low blood. But on the other hand, if the low blood is so low to an extent where it leads to cardiac failure, then yes, your symptoms can get worse. Also, if you've got asthma, or if you've got very mild asthma, which you haven't realized you've got, and then on top of that you get anemia, then you may become symptomatic. So that's because you're not getting enough oxygen coming in from the lungs because of your mild asthma, and then your blood levels of hemoglobin are low, and so you don't take enough oxygen from the lungs and deliver them to the tissues. So your tissues, particularly your cardiac muscle and your lungs themselves, become short of oxygen, and then you may become symptomatic. So you probably do have an associated condition which you might not have picked up before. But if you had pure anemia on its own, it's unlikely that that's going to cause the symptoms.
Oh, okay. Thank you very much. Then shukran.
Jazakallah khair for your call, sister. A very interesting call. So obviously that caller's question was alluding to there may be other factors that sometimes come up and within the diagnostic framework which may distract you from the diagnosis of asthma, or there may be like a secondary cause which is very rare. You maybe want to mention one or two, or are they?
Yeah, I think other conditions would be things like pneumonia, for example. Okay, so you might have mild asthma and you're living with that and you don't realize that you've got mild asthma. And when you pick up an infection like a pneumonia and you end up in hospital, say for pneumonia, that's when they might then suddenly your short breath gets much worse, and you might realize at that stage that you've got underlying asthma.
Okay.
So there might be other conditions that will cause you to realize you've got asthma.
And family history and genetics?
Family history is quite important. Family history is important in terms of atopy particularly. So if you've got a family history of people that have got asthma and allergic rhinitis and eczema, you are also very likely to get those conditions. And in fact, it's as high as 25%. So 1 in 4, if you're an asthmatic and you've got 4 children, you're likely that one of your 4 children will have asthma. Okay. It's as high as that. So genetics certainly is very important.
Okay. We're going to be wrapping up just now, Akhter. Is there any particular aspect that you want to perhaps just highlight or give a take-home message to our viewers?
No, I think your compliance of treatment is very important. There's also a number of devices that are available these days for treatment. And I think the standard device everybody is used to is what we call a metered dose inhaler. And this is, everybody calls this the asthma pump. Okay. But your technique for this is very important. But there's a number of other devices that have been developed, including disc halers, turbuhalers, and then we also get ones where we can actually put capsules into them and inhale them. So there's a number of different devices that can be used.
This make it obviously a bit easier.
Which make it easier for us to actually use. So I would suggest if you're having difficulty in controlling your asthma, you look at a different device. That would be one thing. In children particularly and more elderly people, we can use what's known as spacers. So if you've got a metered dose inhaler and you're unable to use it adequately, you can use it through a spacer. So you would actually put your inhaler on the edge of the spacer, and then you can press that and breathe on the other side. If you've got a child, you can use a little mask. If it's an adult, you can just put it onto their mouth and breathe. So spacers and different types of devices would make a difference in terms of how you can manage your asthma. So there are many ways to skin a cat, so to speak. And if your asthma is not well controlled, then certainly you need to see your physician to see what other options might be available for you.
Jazakallah khair, Akhter. It was a very valuable discussion, a take-home message that most importantly, once a diagnosis is made and you've been put onto medication, the technique is important, and if you're failing in that direction, there are other alternatives. We thank you for your calls today. We've had a very interesting discussion, and inshallah we'll see you again next week on Health Matters, a comprehensive chat. Assalamu alaikum wa rahmatullahi wa barakatuh.